All right. Good morning. Welcome to Project Echo on substance use disorders and pain. Ed Kaiser is our presenter today, talking about providing some updates on Kratom and 7-OH. Get through our usual housekeeping things here. No relationships to disclose for those involved in today's training. We're funded by the State Opioid Response Grant. It comes to us by way of Nebraska Department of Health and Human Services. And again, the CME certificate, there will be a brief evaluation survey that there'll be a link in the chat. There'll also be an email link that comes out roughly an hour after the training. So just complete that survey, and then within a couple business days, I'll email you a certificate that allows you to put your name and date in it. Okay, so just a reminder where we are in our current series. We're in the third of the fourth series here. We've got one more this month in a couple of weeks. Alex Dork's doing one on ER collaboration for OUD treatment. And then we will be off in June, but then back in July and August with another cycle of 4 trainings. And that's about all I got for my housekeeping stuff. I'm going to stop sharing my screen here, and I'll let our Echo panel introduce themselves. Let's see, let's go with you first, Mary.
Good morning. My name is Mary Ellis. I'm a nurse practitioner and an attorney here in the state of Nebraska.
Thank you. And Alex.
Alex Stork, family medicine in Omaha, urban underserved, family med.
Thanks, Alex. Todd.
Good morning, Todd Stoll. I'm a psychiatrist.
Thank you. Stephanie.
Good morning, everyone. Stephanie Bennington. I'm a psychiatrist out in Black Hills, South Dakota, and Western Nebraska. Nice to see you all this morning.
Thanks. John.
Hi, good morning. I'm John Massey, and I'm a pain physician.
Thank you. All right, Ed, go for it.
Yeah, thanks, Will. Good morning, everybody. Yeah, Ed Kaiser here. I'm a family trained nurse practitioner. I live in Omaha, Nebraska, and yeah, excited to be with you guys today. My background, I was a ER provider for a while, then I worked in the urgent care, and then for the last 8 years, I've worked with Ideal Option, which is a company that sort of specializes in treating substance use disorders, but primarily opiate use disorders. So majority of my day is spent seeing patients that are on Suboxone and starting Suboxone and adjusting Suboxone. And so thankful to be a part of this team and to be with you guys this morning. I was looking back, we did a talk on Kratom a couple of years ago. It was 2 years ago in May where we talked a little bit about it. And so there's been some things that have changed. I'm seeing a lot of patients who are coming into treatment really in the last probably 6 to 12 months. And a lot of that is related to 7-OH. And so we'll talk about that a lot more specifically and kind of what that is and why that's happening. But again, just want to highlight, like, we as a team of Echo people are really just thankful that you're here and helping serve this population. And we want to be as helpful of a resource to you guys as well as if you are starting patients on Suboxone or if they have pain questions. Again, please don't hesitate to reach out to us. We love to be a part of those conversations. So yeah, so let's dive in. Kratom and 7-OH. So let's start talking about Kratom first. So what is Kratom? Essentially, this is an herbal extract that's derived from leaves from this tropical tree. It was native to Southeast Asia, and then it was traditionally used in these sort of Asian cultures for really hundreds of years. And the way that they used Kratom was to combat fatigue for laborers, increase their work productivity. And then they also used it in what they said was like traditional medicine for just various ailments. And the reason it can be used for all of these different things is because Kratom in its kind of true form contains multiple alkaloids. And all of these different alkaloids have sort of different psychoactive properties in the body and how it affects us. And so we'll look more specifically at that in a couple of slides here. So when we talk about how to use or how people are using Kratom, when people are using substances, generally they're, taking them orally, or sometimes they inject them, or really the most common form of substance use with the fentanyl and the stuff that's out there right now, as people are smoking it or inhaling it. And people use it in different ways to, get different effects as far as how fast it gets into the bloodstream and gets to the brain. And so, with kratom though, it is a drug or a substance that's used just orally. Most commonly, we see kratom brewed in teas. That's maybe the most traditional way, I should say, that people have used kratom in the past. It does come as well in a sort of capsule and pill form, in a more sort of standardized dosing, although lots of places this is not regulated, so you may be getting different doses. It also comes in just a pure powder form, so you can buy a powder of bunch of powder kratom and just add it to your drink or to food or whatever. And then it also does come in a sort of a liquid extract. So think of like 5-hour energy shot type looking little drinks that you can get. And generally speaking, as you go down that list of ways that kratom is the forms of it, it gets more potent as you go down that list. So liquid extracts are significantly more potent than the tea. As far as dosing of kratom, so in low doses, around 1 to 5 grams, people get sort of this stimulant-like effect that's similar to caffeine. Increases energy, increases alertness, enhances sociability for individuals. And then if you use kratom in higher doses, so greater than 5 grams, you start to begin to get this sort of opiate-like effect. And so patients will get analgesia or pain relief. Sometimes they get into some euphoria, and it can cause sedation. We'll kind of talk more about that. Not super common with just the pure kratom. I think this is sort of a helpful slide as we just think about what kratom does in the body. And again, there's 40 different alkaloids, so we're not listing all the alkaloids here as we look at this slide, but sort of some of the main ones and how they can affect things. So the metragenine, that's sort of the most common alkaloid, I guess you would say, that we see in kratom. It is a partial opiate receptor agonist. So again, this is where you get some of the pain relief and the euphoria from that. When we do drug screening, at least for the company that I work for, when we're testing for kratom, this is essentially what we're able to test for, is this metragenine. That's really the only part of it that really shows up on our drug screening. The second one there, the 7-hydroxymetragenine, that's the 7-OH. So I'm going to skip that one for now. We're going to talk about it on the next slide. Again, as you go down the list there, I know it's hard to read, but it's got, some opiate effects, stimulating effects for some of these. I think one of them is like an alpha-2 adrenergic antagonist. So again, some of this can be like sedating and helpful for sleep. And so there's lots of different things that kratom can do in the individual, depending on sort of how much of each of the alkaloids are in there, or how much of the drug or the substance that they take. This is probably the most important update that I feel like that we're talking about today. And this is the 7-hydroxymetragenine, or it's known as 7-OH. And essentially what this is, again, this is a very specific alkaloid in very, very small amounts of kratom. So generally, when a person is using kratom, less than 2% of it is the 7-OH. The potency of 7-OH is estimated to be 10 to 20 times stronger than morphine. And as you can imagine, that's far more powerful than just regular kratom. This synthetic concentrated form, essentially, what they say is it kind of hit the market around 2023, where we started to see products with isolated sort of 7-OH. And the thing about it is that there was a lot of people who have been using kratom for a period of time, and sort of 7-OH came on the scene. I saw some patients who were getting significant amounts of 7-OH in the products they were using, and they didn't even know it. So it was sort of almost like being snuck into the supply. But then what would happen is people would go to the gas station or the smoke shop or wherever they were getting these substances, and the the people there would be like, hey, if you like Kratom, you're gonna like 7-OH. Essentially, it's like the same thing, and it's just better. And so people were really being tricked, and I don't know the people that were trying to tell them that, but essentially people were getting this 7-OH, and it was a much higher potency, and they started to develop this severe dependence. There is a risk of overdose with 7-OH, and there's opiate-like harms that are the risk is similar to opiates compared to natural kratom. So in July of 2025, the FDA came out and they put out a warning on these concentrates of 7-OH, essentially saying that, hey, these products have the same life-threatening risks as opiates that include both overdose as well as addiction or substance use disorder. This is just a picture that kind of shows you kind of what the products look like. Again, you see the sort of the little liquid shots. It comes in these little pill forms, also in some powder mixes, and then you even get sort of these like candy cane looking thing, or ice cream cone, sorry, looking things that all of this can be sort of marketed towards younger generation, but generally we're seeing this more in the liquid and kind of the gummy and pill form. I think this slide is helpful as you just think about, hey, what are the differences between Kratom and 7-OH? So we've talked about that Kratom is multiple alkaloids, 7-OH is one single synthetic created alkaloid that's very potent. The overdose risk, one of the, maybe the good things about Kratom from an overdose standpoint is that it is relatively low that you overdose on sort of natural Kratom, just because the therapeutic level of Kratom, what people are trying to get from this substance, is much lower than the overdose risk. But that's not necessarily true with 7-OH. There's more concerns for overdose in this. The legality, we'll look more at this at some different slides, but it is legal in a lot of states. There are some states that have banned Kratom, not very many. It has become regulated. And then 7-OH is really becoming rapidly banned, which is a good thing, because there's a lot of people that are really kind of struggling with this. The dependence risk, I'm going to talk about this on another slide, but moderate withdrawals resembles opiates for Kratom, but there's this high sort of rapid tolerance and dependence that can develop with 7-OH, and that's really what's getting people into a lot of problems. I think this is a really interesting slide. It talks about the opiate epidemic in different waves. So, we're all familiar with kind of the prescription pills or legacy opiates that were prescribed. I sort of jumped into treatment at Ideal Option in 2018. So I was like right in this sort of wave. And so I would see a lot of patients who had got started on prescription pills, and then their prescribers stopped prescribing them, and maybe they started getting them off the street. I saw a lot of heroin early on. That was probably the most common things we were seeing in patients that were coming to us who were getting substances off the street. We saw a lot of heroin. We barely see heroin anymore. It's really a drug that is very rarely used or really even out there. And then obviously everybody's familiar with the fentanyl that sort of came on the scene. Started coming out in these, people were using fentanyl. It was like, and then it was in like these pressed pills that you were getting. And then they started going with these rainbow colored pills, or pills that looked like oxycodone, but it was actually fentanyl mixed in there. Now we see fentanyl sort of mixed in most of the drug supply. It's not uncommon for us to see people who are using methamphetamine that's laced with fentanyl. The most potent form of fentanyl that's out there right now that I see is a fentanyl powder. And just to give you an idea, like patients that are using fentanyl powder right now, like they'll come in and they'll say, hey, I'm smoking fentanyl 4 to 6 times a day. So somebody that has a pretty significant tolerance, and they get one bad batch of that with even that tolerance, and it causes an overdose in these individuals where they need sort of multiple Narcans, end up in the emergency department. And so the powdered fentanyl that's out there is super dangerous. And then the 7-OH, again, that came on the scene in 2023, but some of the predictions is that this 7-OH is actually going to be one of the next waves of the opiate epidemic. Again, hasn't been around for a super long time, but it is very accessible. And there's lots of people who get started on it. They don't even know sort of what they're getting started on or what they're getting into. And again, it can cause some really significant problems. One of the ways we look at different substances and sort of how they're being abused and the rise of them is just with poison control outreach. And so this one is just a chart that shows that over the years there's been an increase in calls to poison control related to kratom related products. And then in 2025, 40% of the 708 reports to poison control were among individuals who were using or abusing the substance. And so again, just highlighting that it's getting more potent and more dangerous for individuals. When you think about the marketing, so we're just speaking specifically about kratom. The marketing for kratom, talks about performance boosting wellness sort of supplement, and it's a herbal remedy for opiate withdrawals, for pain, for fatigue, for depression and anxiety. And so, as we looked at that, that previous slide, like there is some truth in what they're saying, kratom can do for an individual as far as the different alkaloids that are in it and sort of what each one of those does. And even as you think about, the lack of treatment for substance use disorder, for opiate use disorder, or for pain, frankly, you can see why people, kind of get sucked into this idea that like, hey, maybe I should try some herbal thing like kratom or something like that to help. And so that's kind of how people get started on it. The marketing on sort of 7-OH, again, sort of this growing concern, but came on the market in 2023, isolated product. I talked about what formulations it comes in, but even some of the marketing around 7-OH is that this is a legal morphine or a legal high. So it targets both sort of recreational users as well as people who deal with or struggle with true sort of chronic pain issues. And so, again, obviously they minimize and omit any of the sort of risk factors that are associated with this. And as I mentioned before, the risk profile compared to regular kratom, increased potency, greater abuse, and more severe withdrawal symptoms with the 7-OH. I think this slide is really helpful. When I first saw it, I thought this was a really helpful thing, and probably the most helpful. So on the left side here is the metragenine. So that's what we think of just like regular kratom, and then obviously we have the 7-OH that we've been talking about, and then the prescription opiates. But when you look at this rapid tolerance, with kratom, it's relatively low. With 7-OH, it's significantly higher, similar to what you see with prescription opiates. The addiction potential, again, with kratom, lower than 7-OH or prescription opiates. Withdrawals for kratom is less than with 7-OH. And down the line, you can sort of look at this. I'll show it the next slide, and I want to talk more about this. Pretty much anytime I do a presentation on any sort of substance use disorder, I really like to use this slide to talk about chronic use of substances, both tolerance and dependence. So again, when we talk about tolerance, we're simply just saying that like, hey, somebody needs a higher amount of the substance to sort of get the same effect of that. Excuse me. To get the same effect of that. And then we get to the dependence where we get into like physical disturbances when the drug is removed. So we're talking about withdrawals, ongoing use that relieves the symptom of withdrawal, but not necessarily to get high. So going back to this side, real quick, rapid tolerance with kratom, low, with 7-OH significantly higher. So the effect of the kratom or the 7-OH versus the timeline. So when I would see patients, when I did this talk 2 years ago, when I would see patients that would come in, and still when I see patients that come in that are only using kratom, it takes them usually, in my experience, a few years of using kratom before they get into any sort of like chronic use problem where they're really using it just to not have withdrawal symptoms. With the 7OH that's on the market right now, most of the patients I'm seeing are coming to see me within 3 to 9, maybe 12 months of starting to use 7OH. So the timeline where they get into this sort of chronic use phase where they're really just using it just to feel normal, and where they've ramped up the amount of 7OH that they're using in a really short amount of time is really pretty staggering. We talked about, we did talk on alcohol last round, and we talked about chronic use with alcohol. A lot of times patients are using alcohol for several years, even up to 10 years or longer of consistent use before we get into this chronic use pattern. And so, again, just highlighting that the 7OH is so potent. It's really affecting people in significant ways. And honestly, the amount of patients that I'm seeing in the clinic that are coming in for this is so much significantly higher. In the same day, I saw a 21-year-old female with no significant history of substance use disorder came in being treated, who had been using 7OH for 9 months. And I also saw a 65-year-old male with no significant history of substance use disorder, whose buddy had a gas station. He started using Kratom and then got switched over to 7OH and was coming to get help because it was getting out of control. Switching back to just Kratom now, some of the side effects of Kratom. You can get into some gastrointestinal issues, some behavioral things, anxiety, dizziness, tremors, some skin issues. Again, acute toxicity is possible, would be more likely with Kratom if people are using sort of polysubstances or other substances with it. But there have been a few case studies that show that has happened. This is just a sort of a timeline of withdrawals. And again, this is information specifically more related to Kratom, but early on people can start to get some of these anxiety, nausea, sweating, 24 to 48 hours with just Kratom. They get, worsening symptoms there. And then eventually they sort of can even get some tremors and shakes and pretty sort of significant withdrawal symptoms. The quote at the bottom of this is that people come in with sort of the Kratom shakes all the time. And this was, information that I was getting even before the 7OH was really on the market. This is from SAMHSA, sort of 7 things to know about Kratom. And we've really talked about all of these things that are listed here on this little handout that can be helpful. But the reason I put this one on here is just highlight number 7. Kratom is banned in the region in which it originates, and it is becoming banned in some states. And so I highlight that just because it's like, if it's banned in the area where it came from, I think that we should really be mindful of that as we're thinking about Kratom just specifically in sort of the dangers that are associated with it. And it's interesting, like I do a talk 2 years ago about Kratom, and I'm sitting here doing the same talk saying like Kratom is terrible, it's causing a lot of problem, it's very dangerous, like be aware of it, right? And when I compare Kratom to the 7OH that I'm seeing out there right now, like it is such a milder form, and yet is still really problematic for a lot of individuals. So this is a Kratom legality map. It's really hard to stay up to date on this because things are significantly changing. The red states on here sort of show the areas where Kratom has been banned. I did mention in the past that that's where you sometimes will see an uptick of legal sales of like tianeptine and things like that in those states. There are a lot of states who have regulations around Kratom, which is referred to as sort of the Kratom Consumer Protection Act. And then there's lots of states where Kratom is legal and as well as unregulated also. The good news about, good news, the update on the Kratom in Nebraska is that in January 1st of this year of 2026, they did pass the Kratom Consumer Protection Act, which does allow Kratom to remain legal in Nebraska. So that maybe isn't a great thing, but it is under more strict consumer safety regulations. So This limits purchases to adults who are 21 years old. Products do have to be registered with the Nebraska Department of Revenue. There is a requirement of independent lab testing that certifies that the kratom is actually kratom. And then it sets this sort of key chemical limit related to the 7-OH that we've been talking about. And again, that must be less than 2% of the total alkaloids that are in the kratom for it to be sold. Again, prohibits sort of this adulterated or contaminated kratom products, and then there's penalties for that. So again, in short, kratom is legal in Nebraska. It is very regulated. It's probably around to stay for the foreseeable future. But those are kind of the updates on the kratom laws in Nebraska. I put together a slide just on the cost comparison of sort of kratom and 7-OH, and then I threw alcohol in there just because I like to talk about alcohol and I needed something else to compare it to. But again, you can see with sort of kratom, the leaf powder or leaf form, most people are using 5 to 15 grams a day. You can see the estimated cost there, both daily costs as well as monthly costs. You can see the 7-OH, on this slide, it's saying 1 to 3 doses a day. So a lot of times you're seeing patients that get built up to like the 100 milligram tablets. So again, the estimated cost can be $10 to $40 a day, and the monthly cost even higher than that, related to what you can read on alcohol in moderate and heavy use. One of the most common things that I'm seeing patients come into the clinic for is they're using kratom, or let me repeat that, they're using 7-OH. They may thought they were using kratom, or they say that they're using kratom, but they're really using 7-OH, and the cost has really gotten out of hand for them. And then they for the first time sort of try to stop using this. This is generally several months into using it, like I'm going to say 6 to 9 months. And that's when they realize how bad it is, how bad the withdrawals are, how they can't sleep for 2 days, how sort of dependent they've become on it. So patients, they never really tell me how much money they're spending on it, but everybody comes in and says, I've wasted, or I've spent a ton of money on 7-OH. And again, this is a multi-million, maybe even billion-dollar industry. And even people talk about how they're handing this out as like free trials of this sort of kratom-like, substance. And that's how people are sort of initially sort of being exposed to it, and becoming dependent on it. And so again, it's super sad and frustrating, and it's really honestly criminal what's going on with the 7-OH right now, and just how people are pushing it. But yeah, just want people to be aware of it, of just the significant danger associated with the 7-OH. So talk to you just about what are the treatment options for kratom and 7-OH. And then after we get done with this, I do have a case study, but we'll open it up for questions as well. I think the top of this is kind of clicked off, but this is the DSM-5 criteria for substance use disorder. Again, simple questionnaire, talks about impaired control, social impairment, risky use. Pharmacological criteria means they have to have withdrawals and tolerance. So the way we've diagnosed this is just, if there's positive 2 on the kratom or the 7-OH, then you can diagnose them with this. The way that we've used the codes is we've historically used this other psychoactive substance dependence uncomplicated. That's how we've documented it, either uncomplicated or with withdrawals. I will say that we have run into some issues using Brixadi or Sublocade for patients that have come in with just like a 7-OH dependence, and this code being rejected. And so we have had to move back to more of a opiate dependence or opiate withdrawal, which I think is accurate based on the symptoms that patients are having. But initially, the first thing we're doing is just asking them the diagnostic criteria. As far as for treatment for kratom use disorder and for 7-OH, again, the current limitations are that there are no FDA-approved specific treatments. There's no randomized controlled trials that have done. The evidence that we're using to treat sort of kratom and 7-OH is primarily from case report series. And the treatment approach for us has really just been the same as what we are treating for opiate use disorders, and with similar protocols related to that. As far as assessment, we talked about always just doing a comprehensive substance use history. So making sure that patients are not using other substances with the kratom or the 7-OH. Honestly, like the patient population that I'm seeing here, like maybe they've had a history of like some alcohol use in the past, but generally they're not using a lot of other substances. It's really like they don't have a significant history of substance use disorder. They get started on some kratom, get transitioned into 7-OH, and really have some significant problems there. Assess pain and mood disorders. You know, we talk a lot about those things, other comorbidities within the sort of ECHO project that we do. But again, a lot of people come in and they're having some sort of back pain or some sort of ailment, and they get offered this, and all of a sudden, as you can imagine, their back pain is significantly better. I literally saw a guy yesterday, 42-year-old male, who's like, I started taking 7-OH. He was like an electrician, I think, and he was just like, I was able to work so much. I was able to work a bunch of overtime. Like I just felt so good, and felt so good until, you know, he didn't feel good and tried to stop. There is recommendations around laboratory testing, liver function tests, some heavy metals. There was some stuff about kratom and some lead poisoning or lead issues. I don't think that's the biggest issue now, but it's worth checking for. And then again, psychosocial approaches, motivational interviewing, always good and effective. Cognitive behavioral therapy, and then support groups sometimes can be limited, specific to kratom and 7-OH, just because it's so new. And then pharmacological treatments, again, you know, medication-assisted treatment. I'm a Suboxone provider. That's what I've done for the last 8 years, so I'm most, you know, familiar with that. But it is a really effective way to treat both kratom and 7-OH. Methadone is also an option. You can also use some of the withdrawal medications like clonidine or lafoxidine. And then some of the other medications, GI systems, non-opiate analgesics for pain, and then some sleep aids, anti-diarrhea medications as needed as well. I just want to kind of re-highlight as we think about the FDA-approved medications for opiate use disorder. Again, as we talk about methadone, methadone is a full opiate agonist, so it sits on that opiate receptor, sort of turns it on all the way. It's a long-acting medication, so it stays in the patient's system long-term. Is a little bit more difficult for people to get right now. They generally do have to go to a methadone clinic where they do daily dosing. Sometimes they do get some take-homes with that. The buprenorphine, again, partial activation of the opiate receptor, so it turns it on to a lesser degree, so we get this partial activation. And then naltrexone does not activate the opiate receptors. It is a pure sort of opiate blocker. You know, we talked a lot about naltrexone with the Sinclair method and how that works. Really just my highlight on the naltrexone from a 7-OH and a kratom use is that if you are using naltrexone for alcohol use specifically, it is very important that you're asking individuals if they are using any kratom or 7-OH, because if you give them the naltrexone and they're actively using that, you are going to throw those individuals into a precipitated withdrawal with that medication. As far as mechanism of action, again, just highlighting that, you know, for this slide, we're saying that the sort of the green thing is kratom or 7-OH, and if that's in the patient's system, if you add the buprenorphine to that individual, the buprenorphine is going to remove that kratom or 7-OH because it has this very tight binding affinity for that receptor. And that's where we get into the issues of like precipitated withdrawals if we don't initiate these patients correctly onto the Suboxone. The other thing I love about Suboxone that you guys are very familiar with is the ceiling effect. So specifically, if patients do have a use disorder and they've abused substances for a while, we can give them up to 24 milligrams of Suboxone. They could actually take 48 or even higher amounts, but they're not going to get any more dopamine activation with more of the medication because there's just not enough receptors. And so the ceiling effect really prevents people from overdosing on this medication. It's one of the reasons that we can prescribe this medication in from a pharmacy, because there's less risk of overdose and abuse. And then again, just a reminder on the precipitated withdrawals. What are precipitated withdrawals? Essentially, it's an acute withdrawal that's caused when there's a high affinity medication like Suboxone or buprenorphine that displaces this full opiate agonist. So most commonly we see this as buprenorphine. Also naltrexone, which I mentioned earlier, can cause this. Narcan, when we give patients Narcan who have overdosed, we're trying to make this happen. We're trying to remove that fentanyl off of that receptor so that they start breathing again. But essentially what happens is people are dependent on dopamine at this level. We give them a substance or a medication like buprenorphine that drops that dopamine drastically and quickly, and that's where they get this sort of sudden acute withdrawal symptom that is really pretty miserable for the individuals. Just briefly, when we think about initiating onto Suboxone, there's really kind of 4 ways that we talk about doing this. There's the conventional initiation, which is really just having patients wait. Usually for us, it's 24 hours, and then from their last substance use, whatever that is, and then we give them sort of small amounts of Suboxone, 2 to 4 milligrams every hour or so, increase that over time to get them to the target dose. The high dose initiation, this is the most common initiation that I use right now in my practice. We use it for fentanyl use, and I am using it also for some of my patients that have high amounts of 7-OH use. And essentially what the high dose is these patients cannot wait 24 hours for the removal of these substances because their withdrawal symptoms get too bad. And so because they can't wait for 24 hours, we have them wait at least 6 hours. We want them to be in some sort of withdrawals, a couple of symptoms. The way I communicate this to my patients is I just say, hey, I want you to be at a sort of a 7 out of 10 personally on your withdrawal symptoms. So I want you to be in some withdrawals. At that point, we give them a high dose of Suboxone, meaning usually 16 milligrams of Suboxone all at once, have them wait an hour, take another 8 milligrams, have them wait an hour, take another 8 milligrams. So up to 32 milligrams on day 1. And then generally I'll prescribe 8 milligrams 3 times a day for these individuals after that. Y'all are very familiar with the low dose initiation. Dr. Massey uses this a lot as he initiates patients onto Suboxone, this is where we just continue their baseline opiate use, whether that's a legacy opiate, whether that's a fentanyl, we can do it with that, or even with a 7-OH. But you just have them continue their baseline use. You sort of slowly give them small amounts of Suboxone and increase that in there. And then they can eventually stop using the legacy opiates or whatever the substance is. And then the most recent one is just a direct to inject, which is what we started doing this last year, primarily with Brixadi, which is one of the new injectables out there. But if a patient has tolerated Suboxone or buprenorphine before, we can have them, as long as it's been like 6 hours is what we usually do, we can just go ahead and give them the buprenorphine injection of the Brixadi. And because it kind of has a slow sort of onset over 24 hours, it helps prevent precipitated withdrawals, and people do pretty well. I'm not going to spend a lot of time on these, but I have had permission to use them from Ideal Option. These are just our patient-facing handouts on sort of conventional initiation, some of the withdrawal medications that we prescribe along that, and then the high-dose initiation, as well as our low-dose initiation protocol. Again, there's different protocols that are out there. These are just the patient-facing ones that we use and have found to be helpful. 2 more slides for you, then we'll look at some questions and case studies. But again, just always highlighting Narcan, recommending that patients have Narcan when we prescribe them Suboxone. The thing I tell my patients all the time is, if a child gets a hold of Suboxone because it's it's absorbed in the mouth, theoretically there could be risk of overdose in those situations. So we do prescribe Narcan to all of our patients. A lot of our patients are abusing substances, so we want them to have Narcan available, especially if they're around someone that overdoses. But Narcan can be used to reverse kratom overdose. Again, kratom overdose probably uncommon, 7-OH more common, but more likely people are getting into polysubstance use. So we still recommend that people have Narcan and use it. And then again, the just a couple take homes. Kratom, historically an unregulated substance with significant addiction potential. It is regulated now in Nebraska at least, so that's a good thing. Again, the 7-OH is a much higher risk of abuse, and then the presentation is going to mimic sort of an opiate use disorder. We talked about the treatment options, and again, just highlighting overdose with true kratom is rare. But it can be higher with 7-OH products. So I'm going to push pause right there and kind of open it up for questions. I do have a case study if we need to fill that time, but Will, have there been questions, or anybody can pipe in if they have questions or thoughts about this?
Thanks, Ed. There's one question in the chat about drug screens, and it looks like Alex gave a good answer on that one. Not seeing any other questions yet, but please feel free to drop those in, or if you want to unmute and speak up, that would be a good time for that as well.
Yeah, definitely. Feel free to jump in anytime. I'll start this case study, and then yeah, feel free to jump in if you have questions, and I will ask some questions here. I'll give you sort of the teaser up front, or the hint. I'm not giving you all the information you need in this case study to figure out what the right answer is. Okay, so let's go over this together, but I want to highlight a couple of things. So this is a 34-year-old female. She came in to see me for evaluation and treatment of what she reported was chronic kratom use. She reported that there was daily kratom use for approximately 7 years, with sort of escalating use over time. She describes this sort of loss of control, unable to stop independently due to the withdrawal symptoms, which is what has prompted her to sort of seek treatment. She reports that her kratom use has been around at the time when she was still using other substances. So she does have some history of some opiates and alcohol use in the past. She initially used kratom intermittently in combination with those substances, but has since just transitioned to primarily daily kratom use. There's a significant history of alcohol use disorder. She had multiple DUIs in the past with some consequences related to that. But she was able to achieve abstinence in 2020 and has been sober from alcohol since that time. So great job getting off of the alcohol. Unfortunately, it sort of feels like she maybe switched over to kratom instead. As far as the opiates go, she had a history of opiate misuse. She said that began after she was exposed to her mother's prescription opiates, who had a failed surgery. Reported she was initially using the medication recreationally due to the way that it made her feel, but her use progressed into sort of this compulsive behavior, which is pretty common. She noticed that she started stealing opiates from her mother, at which point she recognized that she was developing a problem. She reports her last opiate use was in 2021, around the same time as her kratom use became more consistent. At the present time, she reports that she is exclusively using daily kratom, denies any current alcohol or opiate use, and she is motivated for treatment. Says her use has gotten out of hand and she's unable to sort of stop on her own. So, trying to make this interactive, what additional information do you want to know about this patient? You can drop it in the chat or you can unmute. Give you the case in front of you there for a minute. Any additional information you want to know about this patient?
Would you want to know how much kratom she is using daily? Is one of the comments
Excellent.
we got.
Yes.
Yep.
I want to know how much kratom she's using daily. Good. Thanks for jumping in, whoever that was.
Full medical history and other medications.
Perfect. Yes. Absolutely. All right, so let me give you some of that information that you're asking for. So additional information, let's talk about her kratom use, right? So kratom is always a little bit hard to tell how much people are using. But one of the most important things that I think is helpful to know when you're seeing a patient first time is when was their last use of the substance. So her last kratom use was at 9 p.m. last night. As far as how often she's using the kratom, that's another way for us to tell how much kratom she's using. So she can tell us, like, maybe she's using shots or the pills or the tablets, and maybe she can tell us exactly how much. But for this individual, generally she's taking the kratom 4 to 6 times per day. I don't even think I put exactly what she said. So again, we may not always know exactly what it is because a lot of this is unregulated, but last use is very important, as well as how often they're using when they're starting to go into withdrawals. So currently you're seeing this patient in your clinic, we'll say 9 a.m. The next day. So we're 12 hours out from her last kratom use. Currently, she is having some body aches, sweating, anxiety, yawning, nausea. Her vital signs look normal. She's alert and oriented. She does appear to be in withdrawals on examination. This is her first time sort of seeking treatment for opiate use disorder. And she got a family history of exposure to treatment. Her brother was on Suboxone for a period of time, and her brother successfully discontinued opiate use and tapered off of the Suboxone. And so this patient is open to treatment. I think your other one was the past medical history. I maybe have that on a different slide here, which I don't want to give that one away yet because it's kind of the final reveal, but no significant like medical history, not on any medications, maybe on some like PRN benzodiazepines and some propranolol, but nothing other, no other sort of significant medical history related to this. I will say that she mentioned that her brother tapered off of the Suboxone. So I am seeing a lot of people that are coming in specifically with kratom or 7-OH that do not want to be on Suboxone long term. They want to something to help them get off of it, and then they want to be done with it. And so again, just to be mindful of like kratom and 7-OH has not been around for a really long time. So, I mean, it's been around for a short amount of time. And so a lot of times our recommendations around Suboxone are continue the medications while it's helpful for the individual, and not force taper anybody off of these substances. But a lot of times these patients are coming in wanting to get off of the buprenorphine. So excellent question so far. Any additional treatment or any additional information? What treatment options are available? And what do you guys think the best initiation option is for this patient? You can drop it in the chat. Who wants to take some stabs at, since I'm doing the presentation, this patient's going to get started on Suboxone, right? Like that's the obvious one. But how do you want to initiate this? And there's one other sort of key piece of information that this patient is not telling you yet, but you may be able to defer or figure out, decipher, I think is the right word, from sort of the information that we've talked about so far. initiation options are high dose, low dose, conventional. I'm not direct to injecting any of these patients yet. Well, if no one answers, I'm going to put you on the spot and make you answer. How would you initiate this
Oh boy.
patient?
Well, Nicole stepped in for us. Nicole
Oh,
says,
Theo.
thanks, Nicole. Nicole says low dose.
Low dose. Okay, good. Nicole, do you want to expand on that, or are you just going to stick with the low dose answer? It's fine to just stick with it. Any other stabs at it? Okay, great.
As
Let's go
Amy
on. Oh,
says, okay, a question. Amy says conventional question mark. Because the patient's already in withdrawal.
yep, good. That's definitely a reasonable option. And the thing about the withdrawal, the initiation methods is like you can use any of the initiation methods for any of the options as long as we're explaining to the patient, like, hey, this is why we're initiating you in this way, and specifically with the kratom. We definitely can use a conventional initiation. It's probably the most common one that we use. We can also use a low dose initiation. Again, we can start giving them small amounts of Suboxone and tell them that they can continue to use the kratom. Those are definitely good options. What if I told you that this patient was not telling you the whole truth, and what she's told you the whole time is she's been using kratom, but what actually happened is she was using kratom for 7 years, and now for the last year has switched over to 7-OH? Does that change your initiation plan for this individual? Because that's sort of the trick here. She has not told you that she's using 7-OH, but she is actually using 7-OH.
I think that maybe shifted Kelly's response, or Kelly says high dose, I think, in response to that.
Yeah, excellent, Kelly. So again, I put this in here just because I'm actually seeing this pretty often. Is people are coming in, they've been using kratom for a long time, they're still using the language of kratom, but they're actually using 7-OH. So when I pinned this lady down, she was actually using 7-OH. She was using 100 milligram pills, up to 1,000 to 1,500 milligrams per day. So I did finally get the information of like how much she was using, and you would have probably gotten that information from her sooner because you would have asked when you said, hey, how much of this are you using, right? The cost per day of that, again, at that high of a dose, which seems like an astronomically high amount of 7-OH, but you're looking at like $10,000 to $20,000 a month. Now, she didn't tell me specifically. I'm just looking up costs, but you can imagine how this gets out of control for people in a hurry. And again, I think one of the most helpful questions with initiation options is how long can you go before you cannot tolerate the withdrawals? So again, for this person, she's 12 hours into withdrawals. She kind of feels like crap. She has made it this far, and we could give her some more withdrawal medications. My only concern with going with a conventional initiation for this individual is we may give her a little bit of Suboxone, and her withdrawals may get worse because it hasn't been 24 hours. Now, we don't know all the details about 7-OH. Definitely could go with low dose, but I'm really just trying to highlight, like, hey, if you see somebody that's using 7-OH, I do want you to have the high dose option in your brain as something that you can offer these patients. And again, you can start with a conventional initiation, and as long as you're following up relatively quick with these people, if they start a conventional, meaning they start 2 to 4 milligrams and they feel worse or they get into precipitated withdrawals, what they need is more Suboxone to sort of get over that hump to sort of start feeling better. And I've seen a handful of our patients where we've started on conventional for 7-OH, and they've really needed higher doses of buprenorphine to sort of get through that. So again, great job on the case study. There's no wrong answers on initiating because we can try anything. I always like to tell patients, hey, we're going to try low dose or we're going to try conventional. If it doesn't work, don't give up on buprenorphine. Come back and see me or call me or talk to me. let's work through that. And again, just trying to make ourselves available too. Like if you're seeing someone like this and initiating them and it doesn't work, we want to make sure that we're available to you. So one thing with the high dose initiation, I will say, as far as the withdrawal medications go, it's fine to give people clonidine, Vistaril, Zofran before they start the medication, the buprenorphine. So as they're waiting till they're in bad withdrawals, as well as for the first 2 or 3 days after they start the buprenorphine to help with withdrawals as well. So the other case study is just like a straightforward kratom conventional initiation. So that's all I got for you. Will, do you got any more comments here in the last few minutes?
Thanks, Ed. No, we've got a couple minutes. If you have any questions, feel free to drop those in the chat or unmute. We can pause here for a minute while we're waiting. Just note that I did drop the link to the evaluation survey in the chat. You can complete that to claim a certificate for today. That'll also be coming out in an email later today. Okay, a couple questions here. Do you know if Nebraska is considering banning 7-OH? And they have, right? Nebraska has banned 7-OH.
Nebraska did, yeah. So if I didn't make that clear, 7-OH is banned in Nebraska as of January of this year. So that's great news for Nebraska. It's still legal in Iowa last time I checked. Multiple states still have 7-OH being legal, but it is banned in Nebraska. So I feel like that's a pretty good turnaround from coming on the market in 2023 and having that banned. So yeah, good question.
And then with your patients who use Kratom or 7-OH, how frequently do you follow up with those patients?
Yeah, that's a great question. So I like to see my patients once a week initially. The reason is if they're brand new to buprenorphine and we're doing like a high dose or something like that, I should say we will follow up with them 1 or 2 days afterwards, usually just via like a telemedicine thing to just see how the initiation's going, to try to make sure we answer questions. Sometimes when patients come in, they're in significant withdrawals and it's hard for them to like take in all the information that we're talking about. So brand new patient to buprenorphine, I will see them just remotely or touch base with them in a couple of weeks. But I like to give the medication sort of a week at whatever dose, because buprenorphine takes about 5 to 7 days to kind of build up in the individual system. And so I don't like to make significant dose changes that early on. I like them to kind of make sure they're dosing correctly and using some of the withdrawal medications. But like if I start someone on 8 or 12 milligrams for kratom, and then a week later they're coming in, they're saying, hey, I'm still having some significant withdrawals, then I'll bump their dose up a week after. So usually a week after, but I like for an initiation a couple of days after to see how they're doing.
Alex, medical provider at One World in Omaha, just dropped in a comment, says he still sees people on 7-OH, maybe getting it from Iowa or online. Todd, I see you turned your camera on. Did you have something to add?
Just the one thing, there's sometimes difficulty getting payment if you code, if you want to use buprenorphine, and maybe this was reviewed. I had to take a phone call. Maybe this was reviewed about if you, instead of using the diagnosis of OUD, of opioid use disorder. So let me give individuals some things to think about. Low dose kratom is a stimulant. You get into moderate to higher doses, it works at mainly, well, there's multiple, in fact, that's a take-home message, multiple receptors, including the mu1 and mu2 receptors. And if you go back, let's go back to pentazocine. Many of you may not have heard of it, Talwin. It is considered an opiate. It's a mixed agonist antagonist. Its main mechanism of action is through kappa receptors, but it has mu effects as well. And so when you think about Talwin considered an opiate, it's not far-fetched to think about, okay, kratom can be considered working as an opiate as well, given its mechanism. So my point being that it's not unreasonable when you have opioid and mu receptor effects that you treat it like opioid use disorder, and it really looks a lot like opioid use disorder. And I think you can code it that way, especially when you're trying to help a patient get reimbursement, because some insurances will not pay for the others kind of category of unspecified or what have you. So just keep that in the back of your mind, that remember that it's like SSRIs. They're not selective. They work on multiple. Let's take Paxil. It has cholinergic effects, it has dopaminergic effects, it has histamine effects, in addition to various serotonergic receptors. So it's not selective any more than a lot of the opiates are quote unquote selective. So when you have a patient that presents that has effects that are very similar to what we would consider classic, don't forget Talwin, which is even further far-fetched than what 7-OH would be to code it as OUD, and they can get maybe some coverage for from insurance and for the use of Suboxone. So just a side note to think about.
Thanks, Todd. And and thanks, Ed. It looks like we're at the end of our hour here, so we will call it a morning. Let's see, we'll be back in a couple weeks, so please join us then when Alex will be talking about collaborating with emergency departments for OUD treatment. Thanks, everybody. And then Echo Team, we can jump over to that other link for a quick team meeting if everyone has time. Thanks.